Today we will be covering head and neck X-rays by Dr Mycroft Halliwell-Ewen.
Perfect. Good. Right. I'm glad to hear it's the last one. So hopefully you've had a really good set of sessions. That means you're sort of actually generally better at reading X-rays now, and you can sort of recognize bone, soft tissue, work out how things appear in 3D, and we'll just get cracking. The long and the short of it is that, yeah, so head and neck X-rays, generally fairly rare to use them, right, these days. There's a few specific examples, and there's some of the more old school stuff, and I think it's really worthwhile learning about those to do that. But when you're on the wards, you'll often see CT and MRI much more, but there are some specific ones, and we'll go through them. But yeah, so we're really looking for facial bones, sinuses, some skull pathologies, a little bit of soft tissue. Foreign bodies is the big one. Foreign bodies is the big one. But we'll go through and we'll have a look. Same with everything, right? Same with everything. You know, you end up as you progress in your careers, you'll end up you know, these things become automatic. But when you start, right? When you start, it's always good to have a systematic approach to interpretation, and that's actually something we should all be doing, even us clinicians, because most commonly the thing is that the most commonly missed pathology is the second pathology, particularly when you've got something really obvious staring you in the face. It's the second, more subtle finding that gets missed. So there is you know, ABC commonly used as an easy way of doing it. So again, you follow the airway down, right, looking for, is it patent throughout? Are there any foreign bodies in it? Does it look like it's swollen? Then you follow the bones, and the same as I'm sure you've been doing in your other X-rays, you know, not just the contents of the bone, but we're looking for those, in particular, we're looking for those lines, right, to make sure all those bones are in alignment. Then we go on to the cartilage and joints. There's a couple of specific ones for head and neck, but we'll go on. Then we can look at more of the soft tissue stuff, couple of little bits here that we don't really see anywhere else, and then again anything else that we see, right? But we'll move swiftly on, because you're all old hands at this after your series. Right, skull X-rays to start. Right. In terms of views, CT is much better, right? But if you want a general AP view, you can get a general AP view. So we'll just do a little bit of an orientation, right? So there's not really, you know, it's an X-ray, it doesn't go front and back, right? But we've got two orbits, two eye sockets, just looking right at the ear here, right? Just sort of seeing on this side and this side the temporomandibular joint. This is the mastoid bone just behind it. We've got maxillary sinus, nasal cavity, just looking at maxilla here, right, and frontal sinus up here. And this is all skull vault. Okay, we can really see some really nice, we can see the coronal sutures really nicely, right, and we can just about see the soft tissue. We can see there's no soft tissue swellings, but right, we've got an AP view, we've got a lateral view, and it, you know, and we've got some normal ones here. We'll go through some cases, but we're really looking for general symmetry and the odd fracture, particularly in lower resource settings. But it's good to revise the anatomy. So we've got our general, we've got the wide cranial vault, right? Well, the wide cranial vault, and this is the face. It's really actually quite important, particularly for us. One of the most important things to appreciate is we've got nose that's coming all the way out beyond the screen, and brain really sits only in the top. All of this space here, which is most of what we would call face, so really quite far back, is mostly not part of the cranial vault. So it's just good to think about our anatomy. We've got maxilla and upper teeth. Got a couple of lower teeth in here. Right, we have atlas and axis. All right, this is our major airway. Yeah, we've got oropharynx, nasopharynx, nasal cavity, and we can just see the frontal sinus just sitting here. Good. Fine. Now, it is tricky, right? One of the things that you know, it's a lot of these things have been replaced by CT, but this is some of the things you might see in lower resource settings, right? Some of these old school views. We might see so you know, you can just about see, you can do them at different angles, which can help you see things, although admittedly most things have been replaced by CT. So if you do this particular view, right, where you take the X-ray beam at 30 degrees, you get a much better view, and we can see the lambdoid suture here, right? We don't get a good view of the orbits and of the face, but we get a much better view of the occipital bone, right? Right. I'm yet to work out exactly what this is. I think this may well be a CSF shunt. That's what I think it is. Right, but this is certainly external hardware. Right. So we can do it the other way. Yeah. So we can do angled in the other way. And again, this gives us a completely different view. There's no way we're seeing occipital bone through here, but we get a much better view of the maxillary sinuses, of the orbits themselves, and of any of the facial and of any potential facial fractures. Yeah. Right, we'll go through some cases, but it's just to work out there are some of these slight different views that give us different views of different pathologies. So this is where your clinical examination, your clinical suspicion, right, and knowing what you're actually looking for when you request your imaging is really important. If you request imaging flippantly or without much detail, the radiographers and the radiologists are not going to give you, or them the images they need to find the real problem. So just bear that in mind. Okay, right. Let's go through some common pathologies. So we've got some. We'll see some skull fractures. We'll see some intracranial air. All right, and then we'll see some skull lesions. But I think we should just crack on, to be honest. Okay, have a look at this. Take a minute, right, and just have a think about what you can actually see. Yeah. Right. I mean, it gives the game away at the top, right? But we have some skull fractures. Now, some of these are quite difficult to see. This linear skull fracture here, relatively straightforward. You can see it's quite a complex skull fracture. Comes through here, comes through here, comes through here. All right. The skull often breaks in multiple places. What you have to be careful of is not interpreting this suture as a skull fracture, although I think this is fractured through that suture. And this, I think, is also this is a fracture, but it's very near to the suture. And I think that because you can see a break in the cortical bone up here. Okay, everyone with me? Yeah, multiple linear skull fractures, right? Anyone fancy popping in chat anything that they might have noticed about the jaw, right? Particularly the teeth, if we've got some dentists. No. So I think, sadly, these are adult teeth and these are milk teeth. So I think this is a pediatric fracture. And just by looking at the sort of proportions, right, I'm relatively convinced it was pediatric without the teeth. So quite sad, right? I think we'd be needing to send this this patient for a CT to see if there'd been any underlying damage. But this is linear fractures. Okay, so they're fractures through the skull vault, but without changing the overall shape of the skull particularly. Depressed skull fractures are different. So depressed skull fractures, right, linear skull fractures tend to be, or they're nearly always blunt trauma, but they tend to be high energy trauma but spread over a larger area. So things like falling, hitting head, that sort of thing. Depressed skull fractures, right? Depressed skull fractures tend to be from that sort of in-between stage between blunt and penetrating trauma. So not quite penetrating, but not really like widespread blunt either. Things like being hit with a bat or a hammer. All right, this is the fracture here, and it's called a depressed skull fracture because the pieces are depressed into the cranial vault. Yeah, this one I suspect looks to me to be old. I don't think this is particularly new. I think this is an old partially healed fracture, but I'm willing for someone to look the case up on Radiopedia and tell me that I'm wrong. Okay. The imaging is really important with these because actually one of the things that can sometimes happen forensically is that they sometimes the neurosurgeons fish out the bone fragments if they're depressing deep into the brain to decompress it, but also you can sometimes tell forensically important things about the weapon that was used or the instrument that was used by the shape of the skull fracture. Okay. Any questions so far? Just pop them in the chat, no problem. But if you've got no other questions, I'll move swiftly on. Cracking. Good. So we'll do some facial bones and some sinus x-rays. Right. We've seen the view before. Right. Looking at, I mean, you know, Water's view, trying to look at these maxillary sinuses. Yeah. Trying to see whether they are certain things we can see. So sometimes you see foreign bodies, sometimes you can see air fluid levels. I'm sure you've come across air fluid levels before, look a little bit like that. Not the best thing for it. I mean, realistically, sinusitis is a clinical diagnosis most of the time. It's the sort of thing we're doing. And you can sometimes see a zygomatic fracture. So this is the zygoma here. Yeah, it's that arch. Right. Frequently these days we're doing thin cut CTs of facial bones, but you know, you may well come across these and it's worth getting your x-rays worth getting good with x-rays regardless. So let's see, we've got case load. Right.
We just had a question in the chat. If you go 2 slides back, I think.
This one?
Yeah, there's a question in the chat saying, why does it look like there's a dent at the top?
Here, Mariam. Right, this is this is the dent from the injury. I think this dent is just an old x-ray combined with normally where the fontanelle is. So if you feel your own head, right, actually there is the protuberance front and back, and where the sinuses come, where the fontanelle used to be in babies, there is a little dip. Right, I'll see if we can see it. It might be less pronounced. See if we go back to the lateral view. Yeah. Can I convince you there is sort of a dip here if this person straightened their head up more in that direction? Yeah. People do have different shaped skulls, right? That is entirely known and normal. Right. Right. Yeah. So this is another slightly better view that we can get. All right. Got a really good view of the mandible here, but we're also just about trying to get a view of the maxillary sinus, but more particularly when we're thinking about these, one of the few things that I've still seen used for facial fractures is trying to look at the orbital rim. Yeah, seeing if there's a fracture of the orbital rim. I must admit, these days I generally think CT is where we go, but you may not you may not have that available. So we'll do that. Good. Laterals. Yeah, let's have a. This is a really good place to think about some anatomy. You know, face anatomy is really, face and airway anatomy is really good, and you've got a really, really lovely shadow here of the person's face. It's really good, really high quality image. Okay, so hyoid bone, yeah, hyoid bone where all the strap muscles attached to. We'll follow the mandible. We can follow it up into the TMJ. Right, you can just about see this part of the nose is cartilage. This is the squishy bit, but then there's some cartilage doing that, and the skull really only starts here. All right, we can see eye socket, and we can see just how close it is to maxillary sinus, which reminds us when we get chronic sinusitis, the risk of it progressing into orbital cellulitis. But I think the thing that's most appreciated on this X-ray is the airway. Yeah, just see that beautiful nasopharynx, oropharynx, right, and nasal cavity, which is really quite large. It's quite difficult to get to the posterior nasal cavity, but it's really quite large. Very, very interesting. You can see the airway coming all the way down here. Really, really lovely image, that one. Sometimes you can see a fracture in the nasal bones. It is much easier just to look at a nose and see if it is aligned and likely fractured, or you can see it on CT. But what you can only see this line here, really. You can't see the septum, so you can't see a vertical break. You can only see something that's changed in sort of this direction. But most nasal fractures shift side to side, so it's more difficult to see on this. But air fluid level you may well see on here. All right, as well as any mandibular fractures. Lovely. Right. So really good facial X-ray images, and we can see the nasal fracture. Yeah, really good images. Very high quality X-rays actually. So we can see the nasal fracture really, really well. And that's this bit of the bone, right? Remember, with nasal fractures, we're also worried about there being a septal hematoma, which we need to look up the nose and make sure there's no boggy mass that we'll need to drain, or the septum will die. And we don't know how straight it is as well, right? But you can clearly see the nasal fracture in both these images really nicely. Yep. Good. Yeah. Okay. Le4 fractures, right? Le4 fractures are really, really interesting. Again, really they come up repeatedly. I've just had to relearn them for my latest exams last month, right? But they are a triplet of eponymous fractures, and the way it works is that all the different different holes in the bone and the weakness, sort of the way the weaknesses work with the bones of the midface is that fractures, severe facial fractures tend to follow, particularly of the midface, follow this pattern. So they will either cross the maxilla horizontally, which is the Le4 one, or they will cross between the orbits down through the zygoma bilaterally, right, and through in this sort of pyramidal shape. That's a Le4 2. Or you get a craniofacial dislocation where you'll go all the way across the top, right, and then downwards. So have a look at it, right? This is sort of a start. This is a start, but the Le4 fractures have very specific patterns, and they tend to, for example, in particular, say the Le4 2, it will fracture through the infraorbital foramen because it's a weak point, and it follows these weak points. So you get these maintained, constant fracture patterns. We'll see if we can have a go at this one, but I can see there's a fracture here. It looks like there's another one here, and another one here. which for me is, I mean, have a guess. What do you which Lafore fracture do you think is going on here? Don't worry, you don't have to pop it in chat. Just have a think. Yeah, answer's good. I think this is quite likely to be a Lafore 2. All right, and then we've got one. Here we've got that classic pyramidal shape. Yeah. Good. Really worth learning, right? Really worth learning because they come up again and again. I've had to just relearn them all. Okay, orbits, right? Few times that we still use. I've still clinically used some of these fractures. Again, it's a slightly different view. Yeah, what you're looking for is and in particular, right, what is trying to show you with these with this particular view in these fractures is an inferior orbital fracture. So a fracture through the thin part of the inferior orbit. The reason we worry about this, the reason it's kind of called a blowout, slightly dramatically maybe, is that inferior rectus can get trapped in here. Yeah, and then you get, you know, visual paresis, right? The muscle gets stuck, the eyeball gets stuck, and that's a real problem. It needs fixing. But you can just see this little, you can just see the fracture, and you can just see this little soft tissue protrusion, which I think is probably showing us that it's inferior rectus herniating through that fracture, which is going to cause some issues with eye movements. No, sinusitis, right? Sinusitis, right? Again, not something we always diagnose on X-ray. Usually we diagnose it clinically. Something that's really quite common, but can be really quite debilitating and can be life-threatening because frontal sinusitis can develop into subdural empyema, so, you know, intracerebral abscess or pus, and maxillary can go into orbital cellulitis, which can then track back as well. So actually can be quite dangerous. We've got a nice maxillary sinus here, full of air, and we can see on this side, it is not so full of air. This person's probably got a left-sided maxillary sinusitis going on. They're probably having a bad time. Their frontal sinus is nice and clear, right? And it's slightly rotated, but yeah, they're probably suffering significantly from that. We can't tell whether it's gone any further. But just remember, if you're confronted with sinusitis, particularly, you should be checking some cranial nerves, right? And if you've got cranial nerve pathologies, they're going to need a scan because this can track not only into the orbit, but then it can track from the orbit backwards into the cavernous sinus, right? Which is the venous sinus, right? And you can get venous sinus thrombosis in the brain, and it's going to cause you all sorts of issues. Good. Any questions about that one? Sometimes the ENT surgeons will pass a camera. Sometimes the ENT surgeons will pass a camera into the nose, right? Because the antrum's quite high into this sinus, right? And they might just widen it slightly and help the gunk to drain out of the sinuses. Good. Alrighty, moving on. Mandible. Yeah, this is starting to get a bit more clinically relevant again, right? So full disclosure, I'm not a dentist, right? Okay, and as we know, medicine and dentistry are two entirely separate, and never the twain shall meet, right? But we have a couple of different ways of looking at the mandible itself. So your standard view, have a look at the bone, have a look at the mandible itself, look for symmetry, look for those lines, look for any steps in the teeth, right? Sometimes it'll give us fractures, but we're particularly looking at this outer cortex because that's where it'll be disrupted. And, although the mandible is quite an exposed bone and very vulnerable, it's really quite tough. So fracturing it's not actually that easy, although it is quite common. Okay, lateral and oblique view, right? So we're just trying to look, and it's slightly better with this one, trying to look for the ramus, so this side part here, yeah, and just the condyle, which is this anterior part, yeah, and that's the head. Again, generally looking for fractures, right? Sometimes you can see sometimes you can see other problems with the teeth. What happens in my hospital, right? For what happens in my hospital is, and this is all done by MaxFax, who are properly dental trainers. They tend to do an OPG, so an orthopantomogram, which is one of those specific dental X-rays. You bite down on the block, and it projects the whole of the mandible laterally, and it's quite a lot clearer. But this may be all you have. This may be all you have. Ah, there you are. That's what you have. See, much better, right? Gives you good dental pathology. It's also gives you some quite clear, right, bits for fractures as well, because you can look at the alignment and the wide of the bones from both directions. So yeah, generally what's requested by the MaxFax team for fractures, if they haven't seen a full CT facial bones already, right? But obviously anything that's mandibular fracture, they also need to start looking for, you know, loose teeth and other dental pathologies, because that's their job. So let's have a look at some, shall we? Right. Yeah. Okay. Right. Got some lucency here. Right. Yeah. It's given us the diagnosis at the top, so I won't ask, but there are some clues. So this is an OPG, isn't it? Right. We can see there's some lucency, so we've got some destruction of bone, so a destructive process. You can just see the periosteum, yeah, just being lifted off the bone. Same osteomyelitis, same as everywhere, right? You can see destruction, right? We know it's not a fracture because the fracture would tend to go all the way through, and it wouldn't tend to give us this like lucency. It would just give us a nice clean fracture, whereas this is some sort of destructive lesion. There's one more little clue, right? Anybody got one more little clue about why this pushing us towards infection? Anyone pop it into chat? Yeah, well, this tooth has been pulled, right? So, you know, this tooth has been pulled, right? That osteomyelitis, remember, is generally a chronic infection, right? So acute dental abscess progressed to osteomyelitis, right? Osteomyelitis is really, really hard to deal with. Right. Oh, fine. Right. So bisphosphonates. We know bisphosphonates, don't we? Right. Those are alendronic acid, that sort of thing, used to slow down the demineralization of bones in osteoporosis. But long-term use, right? Because you don't get because what you do is you inhibit the osteoclastic activity. So you inhibit the osteoclastic activity, so you don't get that turnover. So you do slow demineralization, but it has a couple of things. One, in the long bones, it'll mean that you actually get more prone to stress fractures, so you can only use them for a few years. But it has this slightly odd reaction, this osteonecrosis of the jaw. It's rare, but it is something those of us who want to go into general practice or orthopedics or geriatrics need to counsel our patients of. Is the rare osteonecrosis of the jaw. It's got quite a classical X-ray appearance. Good. Right. Should we do some fractures? Good. Same as the face. Yeah. Same as the face. Right. fractures tend to come, right, at sites of weakness, right? So you tend to see them in the similar places, but they also need to match the forces applied to them, and you can get quite a lot of different forces applied. If this is fractured, it'll be quite a subtle fracture. It may well be there's a fracture of the symphysis, but I'm not sure I'm convinced. I'm happy for any one of you to tell me they can see it and point it out, particularly those of you who are dental, which is much more than I am. But I think this is actually not a fractured mandible. Possibly here. Or, yeah, but I'm not desperately convinced. Right. It says bilateral condylar fracture. Hard to see here. Right. I could be convinced. Right. I must admit, CT has very much overtaken in diagnosing a lot of these fractures. Right. Okay. TMJ dislocations. Right. Yeah. So that's where it should be. That's the joint. That's where it should be. It is locked open. Yeah. This is really, really painful. Really hard to reduce, because remember, it's the same with any dislocation, right? It's the same with any dislocation. You need to make it worse, i.e. try and get this head just beyond this little prominence before it gets better. And it's enormously painful. All the muscles seize up. If you're emergency medicine inclined, there'll be some videos of a trick where you roll the jaw with a 10mm syringe and get it to pop back in. Apparently, it's I haven't seen it done myself. I've just seen the videos, but apparently, it's the most satisfying ED procedure someone can do, because it gives instant relief and it looks like magic. Right. Okay. Soft tissue neck X-rays. Yeah. We can do anterior view. We can do lateral view. Right. It's not a lot of space in this airway. Looks a little bit swollen. Difficult to tell. Right. Often we use them for foreign bodies more than anything else. Right. Wouldn't say this was desperately normal, but it's always hard, and particularly when you can't adjust the settings. Right. I wouldn't diagnose or exclude epiglottitis, although it's not usually visible, admittedly. I wouldn't diagnose or exclude it based on X-rays, but it would be useful, right, to exclude any foreign bodies, which is important. All right. Again, mostly we're looking here for foreign bodies when we're doing the AP view, right? But this does really show us a really nice trachea. Yeah, I don't think so. Tracheal deviation sometimes happens emergently happens in tension pneumothorax. We shouldn't be diagnosing tension pneumothorax by X-ray, let alone by neck X-ray. Sometimes happens with various lung pathologies, but realistically, we're going to need chest imaging for that. But foreign bodies is what is the real reason. Right. Yeah. So, as I said, don't usually see the epiglottis. When you can see the epiglottis, right, as you can in this X-ray, right, and we get a narrowing of the airway up in here, right, can support a diagnosis of epiglottitis. Generally wouldn't rely on that clinically, right? Remember, epiglottitis is a life-threatening immediate airway emergency, so it's also not the sort of thing that we can wait for the formal report on the X-rays to suggest it. But it is useful Okay. It is useful to show that that is not caused by a potential foreign body, and epiglottitis is much more common in children. Very much less common than it used to be. The Haemophilus influenza vaccine has made it, thankfully, much rarer than it used to be. Right. Yeah, here we are. So again, another pediatric, right? Tend to diagnose croup with a characteristic croupy cough, but you can just about see this so-called steeple sign here, right? Much easier to see anteriorly. You can see the airway narrowing here, but you can just about see it here. Again, I wouldn't. It's interesting to see on X-rays. Wouldn't be using it to diagnose or exclude croup. I think it's much more. It's if you see it, that's useful, but mostly I would be using it to exclude a foreign object as the cause of what I wanted. Okay. Again, retropharyngeal abscess, right? This you might be slightly more likely to diagnose on X-ray, or particularly with imaging, right? Particularly with imaging, less so X-ray, we tend to use CT, right? But you can see the the prevertebral fascia, which should, if you remember other X-rays, be nicely on our on the anterior of our vertebral bodies, has pushed and has been expanded and has pushed the airway, right? And we can even see some gas locules. So this is a massive retropharyngeal abscess, and this is generally life-threatening from both sepsis and from an airway point of view. Very, very difficult to manage, right? Very, very difficult. Needs very urgent operative intervention to secure the airway and to drain, right? Probably would aim for a emergent tracheostomy and then drainage of the abscess. Secure the airway first. Good. Okay, this is a scary X-ray. Anyone tell me what they can see? Excuse me. I know it's a foreign body. You've got that in the title, but anyone got a anyone see what it might be? Yeah. Why do we worry about button batteries? Anybody know why we worry about button batteries? Yeah, they can burn through anything. So, you know, all of the water in all of our bodies is pretty salty. Of one salt or another, salty water conducts electricity. That forms a connection between both sides of the button battery, and it starts discharging its current. So it will discharge its current and burn through all tissue very, very nastily. They're round and shiny. They're round and shiny, so they are. And kids love to swallow them. Kids love to swallow anything. Easy to think it's just a coin on an X-ray. Easy to think it's just a coin. This may well be a coin, but I'm not sure I would take the chance. Right, I'm not sure I'd take the chance. A coin, generally, you can leave to pass. I don't think this is moving anytime soon, so I think this needs extracting. This is a very small child. Good. Any questions? Is it in the trachea or the esophagus? That is a tricky one, right? I would suspect it. I mean, it's much easier to tell clinically. Not at the carina, so that's a narrowing, right? I would suspect it's esophagus, this one, just because the esophagus does narrow as it enters the thoracic inlet, whereas often it also looks too big to get down a rigid trachea. Right, but this is why you get a lateral, right? Again, right, probably a coin, hopefully a coin, worried it's a button battery. This is definitely in the esophagus, isn't it? Because the esophagus is posterior to the airway. Wouldn't matter. I would be just as worried about a button battery for both. And in terms of a coin, it just looks like a coin that's slightly too big to pass on its own. So you're probably going to end up going fishing for that in one way or another. Right. But it's good to know what you're looking for and how much sedation you might try before you need to go fishing it out, and then what post-op care you need. Okay. Right. Have a read. I think you're right. Shall we have a look? Yeah. So, depressed skull fracture, right? So again, this is one of the things to talk about. This is one of the things to talk about, and it very much changes when you're in low resource settings. When I am in my hospital with my remember all my radiation principles is as low as ALARA, so as low as reasonably achievable. If there is a likelihood that I am CTing for a potential intracranial hemorrhage, which I may well do because, right, lost consciousness for 2 minutes, right, probably merits a CT head anyway. I might just go straight for, instead of doing a skull x-ray and then doing a CT head, I might just go straight for a CT head. However, if you were in a lower resource setting, you may choose to observe a patient, do the x-ray, right, and choose to observe the patient. But if you found a depressed skull fracture that might need neurosurgical intervention, you may well need to transfer. Yeah. Good. All right. Moving on. Any questions? All found it? All got your answers? Yeah. We've got orbital fourth fracture, don't we? Yeah. I mean, we've got paresthesia over the right cheek because that infraorbital foramen has been, the nerve inside has been damaged. Right. Restricted upwards gaze because the inferior rectus is herniated through. Yeah, all fits. I think they use a repair, to be honest. There's a bit of blood in the maxillary sinus. And a little bit of a teardrop where the muscle's coming through. Right. Yeah. And we suspect this muscle entrapment because we have a teardrop and we have restricted eye movement. Yep. Good. Any questions on that one? Good. Have a read. Question, who's going to have a look in this child's mouth? Yeah. So this is actually one of the very few occasions, right? This in particular, difficulty swallowing own saliva, right? And terrifying airway noises, where we don't examine the oropharynx. Because putting a tongue depressor down or examining the oropharynx can precipitate just enough anxiety or increase in swelling for you to lose that airway. And if you're doing it in triage rather than in resus or better theatre, right, you may well lose that airway. So, right, this is one of the few times where we're not looking to, a few times where we might not do a clinical examination. Yeah. Happy we can see the signs? Yeah. Just about see the airway narrowing at least. Good. Perfect. Any questions? Anything you think I haven't covered? Stunned silence. Yeah, so epiglottitis, right? Right. Essentially, right. This is our number one priority, right? Airway, right? So we firstly need to move the child to a place where I can get an emergent airway with the most senior anaesthetist that I can find, the most senior airway trained doctor that I can find, because this is a terrifying airway situation to be in. All right. Nebulized adrenaline can sometimes buy you time, because remember, adrenaline, right, is vasoconstrictive. So you can sometimes just buy yourself a little bit of time by just reducing some of that swelling, right? It's generally caused by bacteria, so get some antibiotics in, IM or IV, right? And then secure an airway. I saw one of these in an adult on one of my first ever ENT shifts. I was a locum. It was my first ENT night as a locum. Didn't really know the department. It was non-resident on call, so the registrar wasn't on site. I went to see a patient who has referred as tonsillitis, and went to see them and heard the stridor and saw this patient was drooling. Wasn't very happy with that, so asked for a recess bed, called the registrar, and obviously the poor registrar who'd been all day, is covering all overnight and still needs to do a day's work in the morning. Was suggesting that I continue with some, didn't really believe it was epiglottitis, which is fair enough because it's incredibly rare in adults. I suggested some nebulized adrenaline. Said she said if you want to, but I said you need to come in, and I held firm on that one, and she did, and she came in, took one look at the patient, left the bay, picked up the phone to the head and neck consultant, who similarly walked into the resus bay, took one look at the patient, turned around, called the most senior called the anaesthetic consultant. Anyway, the long story short of it is we ended up doing an awake tracheostomy. The long and short of it is we ended up doing an awake tracheostomy on an A&E trolley, but in theatres. After we looked down with a video laryngoscope and didn't think that urgent intubation was appropriate. Once we'd got the airway secured, actually, a few days of IV antibiotics, right? I think they ended up draining a small abscess with a camera, but a few days of antibiotics. The important thing is to secure that airway. I hope that answers your question. Good. So if you're hearing stridor, Zara, if you're hearing stridor, and if you hear stridor, you'll never forget stridor. Generally, I would think it is entirely reasonable if you have someone who looks really unwell and they have stridor, right? To just move them to a recess bed and get someone who knows what they're doing, right? It's the stridor, the drooling, the not being able to swallow in a child with a high fever screams epiglottitis. That's the thing. And once you see it, you don't forget it. If someone has an acute airway stridor, right, and can't swallow their secretions and looks like they're about to lose their airway, by all means, you don't have to do a clinical exam, but you need to move them immediately to resus and find someone who knows what they're doing. Does that make sense? There are some cases, there are some things where mild stridor is, there are some benign causes of stridor, but they don't look really, really unwell. Once you see it, you'll never forget it, right? If you're worried, go find someone senior to have a look for you. But these people also don't look well, right? You look at them and you think, this person is really, really sick. My blood pressure has suddenly gone very high. Good. Alrighty. Join the WhatsApp, all right? And I hope you enjoyed the session. Thanks very much.